Good morning. Thank you. Welcome to the very first National Cannabis Summit. How about that? Yeah. We have over 43 states represented in this room. I think that's pretty amazing, right? Yeah. Well over 400 of you are here today. So I'm Sarah Michelle. I'm going to be your MC and content weaver of sorts for the next 3 days for our journey together. And I am a 27-year local resident of Denver. So I'm honored to welcome you to the Mile High City, which I now believe has a whole new meaning, but that's why we're here, right? This is, it's really fitting that we're here in Colorado. Because we're one of 29 states where cannabis is legal and one of just 9 that have approved it for recreational use. Legalization of cannabis is a topic of deep discussion and heated debate in state houses across the country and in corporate America. In the headlines of the news and around dining room tables, in academia and in law enforcement. But amidst all this controversy, one thing was missing: an objective national forum where stakeholders like you could come together to discuss policy and regulatory approaches that will enhance public safety, advance research, and improve prevention and treatment. And the word objective is really key here because this summit brings together leading experts in public policy, public health, treatment, and research for a truly objective discussion about a highly polarized issue. Here, over the next 3 days, we'll present the broad spectrum of views on the pressing and complex issues surrounding cannabis use and legalization. When you leave the summit, your core views may or may not change, but we hope you'll have a deeper appreciation for the many perspectives on a very complex issue. We're grateful for the leadership and vision of the organizations that partnered to make this summit a reality: Advocates for Human Potential, the Addiction Technology Transfer Center Network, and the National Council for Behavioral Health. Can we give it up for those 3? It's truly been a partnership, and it's been an honor for me to work with all 3 of them. Each day of the summit, we're going to focus on one of those 3 partners, and today we're pleased to shine a very well-deserved spotlight on Advocates for Human Potential, known as AHP. And it's going to be my privilege to bring up to you Linda, who knows the world of public and behavioral health as a nurse, as a master certified health education specialist, a technical assistance provider, and quality improvement consultant. Linda worked for the Maine Department of Health and Human Services government for over 9 years, overseeing block grant services and then as Associate Director of Treatment and Recovery Services. She has experience in behavioral health, medication-assisted treatment, women's health, adolescent and college health, and Linda currently serves as chair of the Alcohol, Tobacco, and Other Drugs section of the American Public Health Association. Would you please help me give a warm Mile High welcome to your summit co-chair, Linda Frazier.
Good morning. I'm not a tall person. Welcome. Welcome to the National Cannabis Summit. I am thrilled to see all of you, and I want you to know how incredibly diverse you are. So not only do we have 43 states represented, you also represent academics, research, healthcare, clinical services, prevention, and recovery support. You come from federal, state, and local government. You represent the Canadian provinces, public health, health policy, and tribal communities. And we look forward to hearing your ideas, your questions, your perspective as we begin this important discussion of the complicated topic of cannabis research and policy. Neil Schiffman is the CEO and president of AHP, and he had a vision to convene a conversation around marijuana and public policy. Neil envisioned a neutral forum in the middle ground between reefer madness and nirvana. A research-driven conversation that's not dominated by the mythology or the zealotry on either side of the issue. A conversation that supports state and local government who are facing new legislation and are tasked with regulating and creating good, sound public health and policy. The goal of the sponsoring organizations of the National Cannabis Summit is to move that vision to reality, to have the difficult discussion of legalization's impact on issues like youth prevention, drug driving, the role of medical marijuana, pesticides, disproportionate sentencing, the health impact of the use of the cannabinoids, and substance use disorders. Over the next few days, we hope to consider the research, nurture the dialogue, and together take on the important issues that are emerging as we face cannabis public health policy together. Who better to set the stage for this balanced, thoughtful, and sometimes spirited conversation than our opening keynote speaker, Dr. John Kelly, who's not to be confused with John Kelly in the White House. Dr. Kelly is the founder and director of the Recovery Research Institute at Massachusetts General Hospital and is the Elizabeth Spaulding Associate Professor of Psychiatry at the Harvard Medical School, which is the first endowed professor in addiction medicine at Harvard. Dr. Kelly has been a consultant to the White House Office of National Drug Control Policy, the Center for Substance Abuse Treatment, the U.S. Department of Education, and the British Parliament. He is past president of the American Psychological Association's Society of Addiction Psychology and has published more than 100 scientific books, articles, and chapters in the addiction field. But Dr. Kelly doesn't just understand addiction medicine at the 30,000-foot level. He's a licensed clinical psychologist specializing in the treatment of alcohol and other drug addiction. He maintains a private practice in Boston, which has been recognized as one of the area's top psychology practices. Please join me in welcoming Dr. John Kelly.
Hi, can you hear me? Great. Well, thank you so much for that very kind introduction. I'm delighted to be here, to be back actually in Denver. And thanks to the committee for the kind invitation. I was here about a month ago actually at the Research Society on Alcoholism at the other Hyatt down the street, where I thought I was going actually yesterday until the last minute, and then realized, wait a minute, is there maybe this, I thought the Hyatt Regency and the Grand Hyatt, are they the same thing? And luckily I told the cab driver, no, actually it's the Grand Hyatt we're going to, not Hyatt Regency. So, almost didn't make it. Almost didn't make it for another reason too, because the cab driver had a tendency to go through a lot of red lights. In fact, the just coming up to the hotel here, I saw the light coming up ahead. He said, I noticed it went from green to red, about 100 yards to go. So instead of slowing down, he put his foot down and went straight through the red light. And I was thinking, oh, okay, it's the mile-high way of doing things around here. And anyway, so come to another light, same thing. There's about 100 yards to go. It goes from green to red. I'm thinking he's going to slow down. He floors it, goes straight through the red light. So anyway, so I said to him, I said, excuse me, I said, you realize you've just gone through 2 red lights. And he turns around and he says, Don't worry about it. He said, my brother's been a cab driver in Denver for 20 years, never stops at red lights, never has, never will. Don't worry about it. So anyway, so we're close to the hotel and we're coming around the corner. There's another light. This time it's red goes green. So I'm thinking, oh, thank God. So anyway, so it goes green. Anyway, the guy slams on his brakes and stops at the green light. So I'm thinking, I said, what are you doing? I said, it's green. He said, oh no, he said, you got to be careful. He said, my brother could be coming in the other direction. So that's not a true story, but it's based on a true story. Anyway, I am glad I made it. So cannabis, yeah, so as was already said, you know, the hot topic, hot button issue. It rouses a lot of strong emotion for many different reasons, which I'll talk a little bit about. So this is an institute, was mentioned, I started a few years back now, focused on really increasing the value of scientific research for the public good. We publish a free monthly bulletin. You can sign up for it here. We're donor funded. And so please sign up to get a free bulletin and go to the website, recoveryanswers.org. So this is you may have heard this quote before, but for every complex problem, there is a solution that is clear, simple, and wrong. Attributed to Henry Mencken, who is a noted journalist. But certainly this is one problem that is not clear and simple, right? It's complex. Our drug problems and drug policy are very complex. There is supply, there is demand, and how do we address it? And this is really the issue that faces most middle and high income countries around the world, because this is a major substance use and substance related conditions and problems are major threats to public health and safety, as well as conferring a huge economic burden around the world. So cannabis, marijuana, we call it around here, is a drug. It's a psychoactive drug, of course, derived from the cannabis sativa plant. The most psychoactive ingredients, of course, are delta-9 THC, tetrahydrocannabinol, as well as cannabidiol. It produces euphoria, sedation, kinds of sensations that people, of course, enjoy, as well as at higher doses, other kinds of impairments, intoxication, memory impairments, as well as at higher doses, other kinds of psychiatric symptoms like anxiety, paranoia, psychotic symptoms, and hallucinations. It does produce addiction also. There are three, as I'll talk about today, there are three main pathways through which substances, including cannabis, cause harms, and these are addiction, intoxication, and toxicity. One of the things I think of particular concern as this drug is becoming increasingly available and accessible is with young people, exposure among young people in terms of its neurotoxic effect on the developing brain. It's a popular drug. If alcohol, which is talked about as the world's favorite drug, then arguably cannabis is the world's second most favorite drug, both around the world and in the United States. So it's certainly a drug, like alcohol, that people, many people, like to use for its psychoactive properties. This is a nice graphic from the Canadian Drug Policy Coalition, and it really kind of just highlights different policy positions regarding drugs. Up the left-hand side of this graph, you can see increasing health and safety harms that come about as a result of different policy positions. And along the bottom, along the x-axis along the bottom there, you can see different policy positions ranging from the most restrictive prohibition on the left through de facto decriminalization, market regulation, and prescription, and then legalization with many restrictions or full-blown commercialization and legalization. And what you see here is a U-shaped curve where you see harms at both ends, both extremes of policy positions, if you will. One with extreme prohibition, where you get certain types of problems, mostly regarding criminalization, black markets, cartel crime, violence associated with that. On the other end of the spectrum, with full commercialization, market capitalism, you get not those kinds of harms, but different kinds of harms regarding public health and public safety. I'm going to talk about these different policy positions real quick, what their pros and cons are, to kind of set the stage, and I'm going to go into more detail about both ends and are there kind of sweet spots as indicated by this figure in terms of policy positions. So prohibition, we're all familiar with that, right? That just means it's illegal. You can't do it. In fact, it really is about manufacture, sale, and distribution. Interestingly, under the Volstead Act, which was the 18th Amendment, it wasn't illegal to consume alcohol, but it was illegal to manufacture, sell, and distribute alcohol. But today, in most countries, prohibition also means illegal possession and consumption. And it remains, of course, the main policy position federally here in the United States regarding cannabis, but also in most countries around the world regarding substances which can cause harms, hazards, and addiction. Some of the pros of prohibition, of course, to the degree that a drug can cause harm, then prohibition reduces population-level exposure by stigmatizing use and reducing availability and accessibility to exposure to that drug. On the downside, of course, it increases crime, incarceration, criminal violence associated, again, because there is a demand. And where there's a demand, someone can make money off of supplying it. Decriminalization is another policy position, kind of moving along the spectrum from left to right there towards legalization. So less restrictive policy. Here, the goal is to, and this is often confused, as you may know, in the media, oftentimes people criminalization with legalization, and it's a very different policy. It's still illegal to use the drug, but you're not punished for use. You don't get a criminal record, as the word suggests. Rather, you might just get a $100 ticket, like a speeding ticket or a fine, parking fine, if you have up to an ounce for personal use. You can still get prosecuted and criminal record for higher amounts. And again, some of the pros of decriminalization is that it reduces the burden on the police and law enforcement, that they don't have to bring people in, charge them, etc. Rather, they can give them a ticket and reduce the overall costs associated with that. It can also decrease stigma associated with use and increase treatment seeking for people who need it. Some of the cons are that when you move in this direction, of course, the perceptions often change about the degree of harm that may be incurred, which can lead to increased change in perceptions and increased use. But of course, there is also still a black market. Because it's actually still illegal to manufacture, distribute the drug. Now, de facto decriminalization is a kind of a step in that direction. And this is often the case. This is what happened in Massachusetts. Many other states don't enforce the law. So even though it's not decriminalized, it's just not enforced. So police don't bother arresting people, busting people for possession. Rather, they just kind of let it go. So again, some of the pros of that position is that it reduces the enforcement, the burden on police and law enforcement and the judicial system for processing cases of possession, and it decreases stigma associated with treatment seeking. And again, on the cons, they're the same as decriminalization, except that it creates a kind of a legal conundrum, right, obviously, and a political confusion regarding, well, what are we really doing here? Oftentimes, this is a step towards decriminalization. So we move now into market regulation. So down the bottom of that curve where we saw those harms reduce with decriminalization and market regulation, prescription, medicalization, etc. And this is really where the government comes in to regulate a market. So medicalization, of course, we've seen this with cannabis and marijuana. Medicalization of a drug, of course, takes a compound, makes it available for medicinal use, can help sufferers who suffer from a range of disabilities and ailments, and can reduce harms. On the downside, if poorly implemented or regulated or enforced, it can lead to diversion and misuse of the medication and can increase harms, ironically. Moving on to commercialization, so legalization without commercialization. So grow and give, like in Washington, D.C. That would be a good example of legalization without commercialization. It means that it's no longer a crime to use, smoke, consume marijuana. So you can get rid of all of the crime and black market associated with its illegal status. But you don't get the public health harms that one might get with commercialization and targeting, advertising, branding that can come with full commercialization. And then there's legalization with limits on commercialization. And this is really what's done in the states where it has been legalized. There are some limits on the degree to which it is commercially available. So there are licensed outlets, there are pricing, there is age restrictions, it's illegal to consume it and driving under the influence. These kinds of things are often initiated again to reduce the overall negative impact of that particular policy position. And then the final one, which is associated with that very high point on the right side of that curve, which has been associated with high degrees of public health and safety harms, is legalization with full commercialization. And we've seen this to some degree with not unmitigated, unrestricted, but with drugs like tobacco and alcohol. So some of the pros of legalization with full commercialization are it reduces the fear, of course, of recrimination and black markets, the criminal violence associated with that. It retains better quality control, and this is true of all commercialization and regulation. Labeling of the psychoactive ingredients. It can lessen stigmatization of addicted users so that they can get treatment, and they can hopefully get treatment sooner. And it can lead from a economic perspective to increases in jobs and tax revenues, so that can be a good thing. On the downside, it can allow branding and advertising, intended, of course, to increase sales, and produces more population exposure. And to the extent that a drug can cause harms and hazards and addiction, then those will go up in the population as accessibility, availability increase and price decreases. And this can also lead to, as industry makes more money, it can lead to more lobbying for more licensing, lower taxes, and so on. So those are the just kind of quick whiz through these different policy positions on this nice graphic. And I want to go into a little bit more detail about the potential pros and cons of these different policy positions and what we are seeing to some degree and what we might expect as we go down a road potentially of increasing medicalization and legalization. So now we have, of course, a number of states that legalize marijuana for recreational use, about 9 including Washington, D.C. Jurisdictions. And about 29 states have medicalized it. In many states, it's also decriminalized. Few states have neither. So it started really, the backdrop for the legalization was medicalization. So this really, I think, softened the idea that I think most of us had since the declaration of the war on drugs, and probably even before that, since the 1970s, that all illicit drugs were bad and legal drugs were good. And how do we get around that? So if you're trying to legalize a drug and move it into a legal status, then this could be a good avenue, because you can soften the blow by pointing out its therapeutic potential. And this is what has happened. There is no doubt marijuana, the ingredients of compounds in the marijuana cannabis sativa plant have therapeutic value, and I'll show you that in a second. But it was never tested with smoked marijuana, and this was the idea with medical marijuana. It was to allow, not a prescription, but a recommendation from a physician to use the drug for a variety of different conditions. And if you read in some things online or for proponents of it, it can actually address up to 259 medical conditions, which immediately made me suspicious, because there are only 117 known medical conditions. So there was some new ones that were being treated also, which is interesting. But certainly, as I mentioned, there are therapeutic components and compounds in the cannabis sativa plant, and these have been extracted and formally tested by the FDA, and there are FDA-approved medications for treating a variety of ailments that have been examined, and these include very strong positive effects of extracts from the cannabis sativa plant as an antiemetic effect. So if you're taking chemotherapy, for example, it can actually reduce the sense of nausea and vomiting. Very strong evidence there, evidence for analgesia and for spasticity in multiple sclerosis. So we do know that as the extracts of the plant have therapeutic value, and this is what people anecdotally report when they smoke it, of course, and a big part of the rationale for recommending it is that people get therapeutic benefit from these compounds. We just don't know what's what with smoking it. We don't know what's in that. It's unregulated in terms of the contents and structure of the inhalants, and that can lead to problems. It has been studied, but of course one of the problems is the unblinding issue with the evidence for smoking marijuana, because people often know that they're smoking marijuana versus the placebo, which can unblind it, and that is a threat to the internal validity of the study. Not to say that it doesn't have therapeutic value, it does, but we just it's much harder to study it when it's inhaled and smoked. So why should marijuana be illegal, or why should it be legalized? This is a study by David Nutt, who has the unfortunate name of being a nut, and he was viewed as a nut actually by the British government and was ousted, fired. He's a very highly regarded psychopharmacologist from London, but he actually has replicated this now with two different groups, one in Great Britain and one in Europe, looking at the harms associated with different drugs, both licit and illicit. And he got these 20 experts, different types of experts of different clinical expertise, to rate the harms of 20 different drugs. And these are 16 criteria. It's a bit hard to see those, but essentially those are things like drug-specific mortality, drug-related mortality, a variety of different harms to the user, indirect and direct to other people in the environment as a result of use and intoxication, as well as harms to the environment, economy, and so on. You can see those down there. And this list of 20 different drugs, up from the left to the right, cannabis falls about in the middle. as rated by these different these experts across these 16 different criteria. And the government at the time didn't like this kind of thing because it showed that, you know, alcohol in fact was viewed by these experts as actually the most harmful overall. That's the one on the left. That's in terms of the drug-specific mortality, indirect mortality and disease, disability, but also harm to others. Alcohol was very big on harm to other people in the environment. As we know, it affects, drunken behavior affects other people close by. But heroin and crack cocaine actually were more harmful directly to the user. Alcohol was third when you looked at just harm to the user themselves. But cannabis, as you can see, kind of in the middle regarding overall harm, and was ranked about the same for harm, specific harm to the user. So what are the arguments for legalization for cannabis? Well, these are some of them. The war on drugs has failed. You know, we're locking people up. 5% of the world's population, 25% of the world's prisoners. 2.5 million locked up, about half a million of whom are there for drugs. There are racial disparities. This is a big one. Racial disparities in incarceration, despite the same prevalence of use, and that's a very important one. Legalization would reduce arrest and criminal justice costs. In 2013, 41% of all illicit drug-related violations were for marijuana possession. That's about 700,000 arrests, about half of all the arrests to do with drugs. Demand is high. They're going to do it anyway, so why not regulate it and make it safe? It's not bad, or not as bad as alcohol and tobacco, and it could be even good for you. It's medicinal. And if you tax it and bring it in, you can bring in revenue for states and provide jobs. So these are some of the arguments, of course, for legalization, and the quote-unquote failure of the war on drugs, the desire we have in this country to lock people up doesn't pertain just to alcohol and drugs, of course, but also to many other crimes. We lock up a higher proportion of people in this country than any other country. You can see since the war on drugs was declared, there's been an increase. Again, not all of those are drug-specific crimes, but about 80% of prisoners have a history of an alcohol and drug use disorder. Part of the problem has been this. This is a California prison. This was once a cafeteria. And you can see triple stacked bunk beds in this cafeteria in California. So legalize, right? So let's legalize it, and then we can get rid of all the bad stuff and just have the good stuff. So what are some of the challenging arguments against legalization? So of the 2.5 million prisoners in the US, about 500,000 are there due to the drug law violations, but only about 40,000 are there due to marijuana specifically. In any case, this would be justification for decriminalization and not legalization. But even so, to end the war on drugs by legalization of marijuana would not do it. What will happen, as I mentioned, is that you're going to reduce the number of arrests drastically, right? 700,000 arrests for marijuana possession. So if you legalized it, you would get rid of all of that. That's half of all drug-related arrests are for marijuana. So that would reduce a huge burden on police law enforcement. How to legalize is a question. So in industry, the majority of the market is heavy addicted users. So if you look at industry itself, for the industry, for the tobacco, alcohol, and marijuana industry to function, they have to rely on heavy users. About 20% of the users are smoking half or more of the product. Okay, so about 20% of alcohol users drink 80% of the alcohol. So for that industry to be able to thrive, it has to rely for its profits on the heaviest users of that substance. It's these people who are spending the majority of their disposable income and more on the product that industry relies on. So in other words, they have to be able to get those heavy users into the pool of buyers. If we make it more available and accessible, cheaper, remove the social stigma because now it is legalized, and the legal penalties, and have industry aggressively advertising it, use will increase. And they're possible. It is possible that marijuana could have a subtractive effect on alcohol, and that could potentially be a good thing because alcohol does, I think most people would agree, cause more harm overall than cannabis. So prohibition doesn't work. Everybody knows that, right? This is the often quoted statement. So what do we need to do? Let's tax, regulate. We'll legalize it, regulate it, tax, and educate. And we can educate people as to the harm so that they'll make an informed decision and then not use it until they're 21, and that will be a good thing. So when we look at a case like alcohol, we know that the 21st Amendment, of course, was intended to reduce the overall harm caused by prohibition. So did it actually end our alcohol problems or dramatically reduce them as a function of reintroduction and commercialization? Well, if you look, let's just take addiction cases. So these are cases of alcohol use disorder compared to all other drug use disorders combined. These are the latest criteria from the latest epidemiological survey. We have about 3 to 3.5 times more cases of addiction for alcohol than all illicit drugs combined, both when you look at lifetime disorder as well as past 12-month use. Alcohol is an addictive drug. Of course, the majority of addicted cases, we have about 22 million cases of meeting criteria for a substance use disorder. About 16 million of those 22 million are for alcohol each year in the United States. Alcohol is a level 1 carcinogen. It's known to cause cancer. Doesn't take very much alcohol to increase your risk of cancer. 20 grams of alcohol a day, that's just under 1.5 drinks, increases risk of breast cancer in women by 25% relative to women who don't drink. It increases risk by 86% of esophageal cancer relative to people who don't drink. Okay, that's just 20 grams, less than 1.5 drinks a day, increases risk of cancer. 40 million people, these are people who don't meet criteria for an alcohol use disorder, also drink at harmful and hazardous levels, causing toxicity-related harm and intoxication. There are 100,000 deaths attributable to alcohol each year. It's the third leading preventable cause of death. Many tens of thousands are killed in road accidents. There is a huge economic burden, about $250 billion a year in lost productivity, criminal justice, and healthcare costs. And the revenue from tax is about $15 billion. So who makes up that shortfall? There are, again, end of prohibition was supposed to reduce all the criminal justice and criminal activity. But don't forget, when you legalize a drug again, as was the case with alcohol, it doesn't mean everybody's going to obey the regulations around that drug. 3 million arrests related to alcohol every year. Those cost money. And therefore, if prohibition didn't work, it's hard to make the case that legalization is the solution, right? When you look at that. So why is it, if the majority of cases of addiction are alcohol, and alcohol causes cancer, how come we don't have that on containers of alcohol? How come we don't have a label saying this may cause addiction? It's the major contributor to addiction cases of those 22 million every single year in the harm, 100,000 deaths a year. Cancer. Why doesn't it have on the label, this causes cancer, alcohol causes cancer? How come? So part of the reason is the same reason why nicotine is not addictive and cigarettes are not addictive. Some of you may remember this from 1994. These are top executives from the major tobacco company, and you can see this video on YouTube. The congressman said, "Oh, let's go down the line. I want you to tell me, is nicotine addictive? Are cigarettes addictive?" Every single one, this was in 1994, not that long ago, said, "No, tobacco is not addictive." Every single one. You go down the line, no. Nicotine is not addictive. Cigarettes are not addictive. This was after the Surgeon General had already published a couple of reports saying, we know the harms are around nicotine and tobacco. They are addictive. They produce all kinds of harms. So it depends on your viewpoint, right? And there can be strong industry lobbying against putting labels on containers. It took a long time for that to happen with tobacco. So corporate profit and industry, of course, as we've seen with tobacco, as we've seen and we see with alcohol, and they're trying to increase their profits. They're an industry. They're trying to market and create seductive labels and bottles and to try and increase consumption. But as we can see in the case of tobacco and alcohol, there are huge public health and safety impacts. So how do substances cause harm? I mentioned this already, the three pathways. We tend to default to addiction, right? We think of, yeah, someone's addicted, that's what we've got to worry about. But addiction is only one of the pathways through which substances cause harm. There are two others. One is intoxication, and one is through toxicity. And you can have, again, they're related, but independent. Addiction causes certain types of problems, acute and chronic, including intoxication and toxicity. But you don't have to be addicted to be intoxicated, fall down the stairs and break your neck, or get into an accident. The same with toxicity. You can have toxicity-related effects caused by exposure to a substance to the extent that it can cause toxicity-related effects, and never actually suffer from addiction. For example, half of liver cirrhosis cases, liver cirrhosis, alcoholic liver disease, do not meet criteria for alcohol disorder. They don't meet criteria for addiction. Half of all liver cirrhosis cases. And the ones that do meet it at a very low level. Okay. Now, why is that? Well, part of the reason is because people who you have to drink pretty steadily over a long period of time to get liver cirrhosis. Okay. The more florid cases of addiction tend to happen quickly, and they're either dead or they're stopped or they're in prison before they're able to get to that stage. So the more florid manifestation, the more heavier the addiction syndrome, the less likely it is. So you can see there are reasons for these different related harms that cause different effects. Now, is cannabis addictive? Yes. So some people, including clinicians and folks out there in the world, think it's not addictive. I was at a school in South Boston, and a social worker said to me, now the kids tell me that marijuana is not addictive. I know it's not addictive, she said to me. I was stunned to hear a social worker in a school say that she knew that it wasn't addictive. Okay, so we know that cannabis causes intoxication, brain changes, and it causes addiction. It causes compulsive use. It meets criteria for the same medical syndrome as other drugs. And we see this dose-response effect with regular use. The more regular you use it, the more likely you are to meet criteria for a cannabis use disorder, particularly if you start when you're young. And again, this relates to a very important issue, I think, from a public health standpoint regarding cannabis, of exposure among teens. These are data from the national survey. These are national population data that are collected every year. We have about 10% of the population each year using some kind of illicit drug. The majority of those, as I said, alcohol is the world's favorite drug. Marijuana is the second most favorite. And you can see here 22 million people have used marijuana in the past month. You can see other drugs, analgesic pain relievers, opioid pain relievers are the next one, but they're much, much smaller number. Of those with a substance use disorder, so not just past month use, but meeting criteria, medical criteria for a substance use disorder. Again, alcohol is the big one. If you look at all illicit drugs combined, it's about 8%, and then marijuana is about half of all those substance use disorders of all illicit drugs combined. So a large number of people are meeting criteria for substance use disorder who are using marijuana. When we look at treatment received, again, alcohol is the big one, followed next by marijuana. And it is addictive. Now, some of those are going to be court referrals, so that would increase. Doesn't mean they don't meet criteria for a substance use disorder, but that increased number among those illicit drugs anyway could be in part related to criminal justice referrals. And what we've also seen is increases in the overall prevalence of cannabis use disorder in more recent years as our policy landscape and our cultural zeitgeist around attitudes around marijuana have changed. These are data again from a national epidemiological survey conducted in two times, one in the early 2000s and again in 2012, 2013. And there's actually been a doubling in the prevalence from 1.5% to 3% of the population meet criteria in the past year for a marijuana use disorder. So as attitudes, as exposure in the population has increased, as potency has increased, so has cannabis use disorder. This is not a surprise to me or to people like me, of course, is that accessibility, availability, and potency will increase number of cases, and in this case, the proportion of cases. So what about toxicity? So this is another very important pathway through which substances can cause harm. Addiction, intoxication, and toxicity. What about, we're kind of thinking about adults and adolescents here. So in this systematic review, this was a meta-analysis conducted and published in the Journal of Clinical Psychopharmacology. It was a well-done, rigorous review. They looked at adults, and they were looking at residual cognitive impairment among adults who were heavy users of cannabis. What they found was, in the first analysis, was there was some residual impairment when people stopped smoking cannabis. There was about 20 days, up to 20 days of impairment. But when they looked after that, when they looked at to 25 days in the bottom bullet point here, they found no cognitive impairment after 25 days among adults. So when they abstained, there was no cognitive impairment on fairly sensitive neuropsychological tests. What about, sorry about that. What about among adolescents? Now, these are data from our lab. This is a couple of studies conducted by Randy Schuster and colleagues at the Center for Addiction Medicine at Massachusetts General Hospital. And she tested adolescents who were cannabis users versus controls who were not, matched on other variables. And what she found was that among adolescents, there was neurocognitive differences in terms of for memory and learning. So those who were cannabis users tended to be less well able to learn and memorize lists of information compared to controls. In another study that she did, she looked at the effect of abstinence on adolescents and young adults. So she paid adolescents and young adults to be abstinent, to get them abstinent, and then looked at their effects on neurocognition. In this case, it was reaction time and reaction time variability to measure responsiveness to cues and reaction time. And the other one was on psychiatric symptoms, to see if psychiatric symptoms actually changed as a function of abstinence. And what she found was that when people abstained for 30 days, that their reaction time got better, so they were more responsive to cues in the environment, and the variability of the reaction time, so they're more consistent in their responses to things in the environment. And also the psychiatric symptoms went down with abstinence. So there was psychiatric improvement with abstinence in terms of depression. Now we've known for a long time now, last 25 years, that our brains develop from the inside out, back to front, and there are certain critical periods of human development which place us at particular risk for insults and injuries that can have lifelong ramifications. And this is why we have age limits, restrictions on when you can first use alcohol, for example, and also now with cannabis. It's now 21 for cannabis. And part of the reason is that we're finding out, just like alcohol, that cannabis during this period of adolescence can have a neurotoxic effect. This was a study called the Nuneaton study. It's been criticized, but I think they've rebutted the criticisms pretty well. There are always confounds in studies, and studies always have limitations, so they're always up for criticism, and no one study is perfect. This is why we need more research. But this is a very intriguing study in that they followed 1,300 people for 25 years. They tested them, their neurocognitive functioning by way of IQ at age 13 before they'd been exposed to alcohol or other drugs, and then followed them up at regular intervals up until age 38. What they found in this study was that adults who were heavy users, if they started using as adults, they didn't have a neurocognitive impairment related to cannabis use. Where they did find an effect was if you were a heavy user prior to the age of 18, you had long-term detrimental effect on neurocognitive functioning, which could not be explained by other factors, couldn't be explained by alcohol, tobacco, other drugs, other experiences, other psychiatric illness. It was attributable, as far as this study was concerned, to exposure, heavy exposure to cannabis as an adolescent. In fact, what they found was an 8-point drop in IQ for those relative to those who did not smoke heavily during teenage years. Those who did, that's dropped to 8 points. So that's going from the 50th percentile to the 29th percentile. So that's a big drop in IQ. What was also noteworthy, that was just one method, what was also noteworthy in that study was that other people in the environment noticed it. So when they asked significant others who were had lived with the person, how's your significant other functioning, how's their memory, their attention, there was a discernible difference among those who had smoked only as teenagers in terms of their memory and attention. So those individuals, again, smoked as teenagers, were more likely to show observable impairments in memory and attention even when they stopped for a year or more. So the other thing to remember about that study was that was done, it was published in 2012, 30 years ago when marijuana potentially was less potent. What we have seen is an increase in potency of marijuana. So it may be, again, toxicity is in the dose. Right? You could have a little bit of cyanide. It wouldn't poison you. Doesn't mean it's not as poison, right? So it's still a poison, but it's in the dose. So it depends on how much we are exposed to that will determine its potential negative impact. So as potency increases, we might actually see, especially with young people exposed to it, increases in the harms that can come at this critical period, as I mentioned, of development. We're understanding now why it is that certain, and we don't know what those active ingredients are in THC, because cannabis has many different oils, we don't know which ones are causing the damage per se, whether it's THC or cannabidiol or some other cannabinoid